Welcome to episode 23 of the Pro PA podcast. I'm your host, Prof. G. Today, we're wrapping up our pulmonary circulation series with a clinical medicine brief on pulmonary edema. Pulmonary edema is a key topic for PANCE prep and clinical practice, and recognizing its signs, causes, and treatments can be life-saving. In this episode, we'll cover the basics, clinical presentation, diagnosis and workup, management overview, and of course, we'll end with vignette-style questions to test your knowledge. Let's dive in. First, let's look at the kinderpatho. What is pulmonary edema? Well, pulmonary edema is the accumulation of fluid in the alveoli and the lung interstitium, leading to impaired gas exchange. And it can be classified into two types. One, cardiogenic pulmonary edema, and this is caused by increased hydrostatic pressure in the pulmonary capillaries due to left-sided heart failure. And two, it can be non-cardiogenic pulmonary edema, and this is caused by increased capillary permeability leading to fluid leakage into the lungs, similar to ARDS, sepsis, or trauma. And I like to really compare pulmonary edema to a pleural effusion. The main difference is the anatomy of it, right? So a pulmonary edema is within the alveoli and the lung interstitium, whereas a pleural effusion is in the pleural space. But they still have very similar characteristics, right? We did see that in a pleural effusion, we had increased hydrostatic pressure or decreased oncotic pressure that were causing the buildup of the fluid there. Well, it's sort of similar in the lungs themselves. We just have to subdivide it into that cardiogenic and non-cardiogenic, but the patho is somewhat similar, right? To either increased hydrostatic pressure or decreased oncotic pressure or increased capillary permeability. So what are the causes of pulmonary edema? Well, we kind of alluded to this earlier. We said there are cardiogenic causes and non-cardiogenic causes. So let's first look at the cardiogenic causes. The first one and the most common is going to be left-sided heart failure. So especially acute decompensated heart failure, we're going to see a pulmonary edema develop because of this. Another cause could be a myocardial infarction or heart attack, and this causes reduced cardiac output and backup of blood into the lungs. Another cause could be valvular heart disease, so especially mitral or aortic valve dysfunction, you can see backup of that fluid into the lungs. And then number 4, a hypertensive emergency. So a severe elevation in blood pressure can also lead to some heart failure and thus get the backup of fluid into the lung spaces. Now, the non-cardiogenic causes that I want to make you aware of are number 1, ARDS or acute respiratory distress syndrome, which we will cover actually in the next episode more in depth. We can also have an infection or sepsis that can cause pulmonary edema. An aspiration pneumonitis can cause pulmonary edema. High altitude can also cause pulmonary edema. And toxins or inhaled irritants, drug overdoses, those can also put patients at risk for developing pulmonary edema. Now, how do these patients present? Well, the typical clinical presentation, the symptoms are dyspnea, so often sudden and severe, orthopnea, which is the worsening shortness of breath when lying flat, paroxysmal nocturnal dyspnea or PND. So this is when you can't really lay flat, you have to wake up gasping for air. And cough, so may produce kind of this frothy, pink tinged sputum in severe cases. Now, physical exam findings, we would expect to find some tachypnea and tachycardia because of the pulmonary edema, maybe some crackles or rails on auscultation where you can hear that liquid moving in those alveolar spaces. You can also sometimes notice some elevated JVP or jugular venous pressure in the cardiogenic type of pulmonary edema. You can also see some peripheral edema in cases of heart failure, and you might notice hypoxemia on pulse oximetry. Now, how do we work up these type of patients? Well, initial imaging, like with most things that we've seen so far in our pulmonary module, chest x-ray is probably the first thing that we're going to do for these patients. In a cardiogenic pulmonary edema, we might see some bilateral pulmonary infiltrates, maybe some Kerley B lines, cardiomegaly, or even pleural effusions to go along with it. In the non-cardiogenic, we might see some infiltrates that are more diffuse without cardiomegaly. Now, we can also step up this imaging and get CT scans, and this might be useful for identifying the non-cardiogenic causes like ARDS or trauma. In addition to the initial imaging, we also want to consider doing some laboratory studies. The number one we're going to consider is a BNP or B type natriuretic peptide, and this is going to be elevated in those cardiogenic pulmonary edema cases due to the heart failure. The other lab test that I would consider getting is an ABG. This will probably show some hypoxia or maybe some respiratory alkalosis. We would also want to get the basics, a CBC, a BNP. This is to assess for a high white cell count in an infection, maybe some anemia, or electrolyte imbalances. An EKG is going to be crucial here. We want to evaluate for left ventricular function, valve abnormalities, and overall cardiac function. And we also might want to consider getting a capillary wedge pressure or CWP. And this is measured via the pulmonary artery catheterization that we mentioned in the core pulmonale pulmonary hypertension lecture. An elevated CWP greater than 18 millimeters of mercury is going to confirm a cardiogenic pulmonary edema. So, management. Let's start with cardiogenic pulmonary edema. I have a little mnemonic for you for the cardiogenic pulmonary edema, and that is LMNOP, just like the alphabet says. So LMNOP, L is going to be our Lasix or furosemide, and this is for diuresis, to get some of the fluid off. M is morphine, and this is mainly for symptom relief if they're having a lot of pain related to it, but please use this with caution as it can depress their respiratory system more. N is going to be nitrates, and that is to reduce preload and afterload. O is oxygen, and this is what we will give for hypoxemia or even just to keep the patient stable. And P is positive pressure ventilation, and these are going to be our CPAPs or our BiPAPs, and these are in severe cases to help keep that PEEP, to keep that pressure up so that when we exhale, we keep those alveoli open because the edema that builds up within the alveoli can sometimes wash away some of that surfactant that's in there to keep that surface tension low. And so we might see some of that collapse, and it might be harder for patients to then take the deep breath back in. So the positive pressure ventilation is going to help them keep those airways open. We also want to treat the underlying causes. So if we have an acute MI, we want to do the whole acute MI thing with aspirin, beta blockers, nitrates, and revascularization. If we're in a hypertensive emergency, we want to rapidly control the BP with those medications. Now let's look at non-cardiogenic pulmonary edema. Mainly, we're going to do, first off, supportive care with oxygen therapy, and then we really need to tackle the underlying cause. So if it is ARDS related, we want to give the patient some mechanical ventilation with low tidal volume. And as we recall, ARDS is most often due to sepsis. So if it is sepsis related, we need to give those essential IV antibiotics and fluid resuscitation. If it is related to the altitude, we need to get the patient out of that high altitude, so immediate descent to a lower altitude, and we need to replace their oxygen. Now, there are some emergent interventions to consider here, one of which we've already mentioned, intubation. So we need to have a low threshold for intubation in these patients because they can develop severe respiratory distress or impending respiratory failure very quickly. Also, we might consider doing ECMO, which is considered in refractory cases of ARDS. All right, some quick clinical pearls. So, number one, always distinguish between cardiogenic and non cardiogenic causes. As the management we've seen, it differs. Also, pink, frothy sputum is a hallmark of severe pulmonary edema. Number three, in cardiogenic edema, the chest x ray will often show these Kerley B lines and cardiomegaly. Number four, high altitude pulmonary edema is treated with immediate descent and oxygen, not diuretics. And last but not least, BNP levels are highly sensitive for cardiogenic edema, but should not be relied upon in isolation. So we want to put the whole picture together in this case. All right, so we've just gone through all of the steps to approaching pulmonary edema. So now let's test our knowledge with a few questions. Number one, a 70-year-old female with a history of heart failure presents with acute dyspnea, orthopnea, and pink frothy sputum. Chest x-ray shows bilateral infiltrates and cardiomegaly. BNP is elevated. What is the most likely cause of her symptoms? Is it A, acute respiratory distress syndrome, B, high altitude pulmonary edema, C, cardiogenic pulmonary edema, or D, non-cardiogenic pulmonary edema? I'll give you a few seconds. If you said C, cardiogenic pulmonary edema, you are correct. The presence of heart failure, elevated BNP, and cardiomegaly point towards a cardiogenic type of pulmonary edema. Now, question 2, we have a 35-year-old male. He presents with dyspnea and hypoxemia after a hiking trip to a high altitude. Chest x-ray shows diffuse pulmonary infiltrates but no cardiomegaly. Which of the following is the best initial treatment? Is it A, Lasix or furosemide, B, immediate descent and oxygen, C, CPAP, or D, IV fluids? I'll give you a few seconds. If you said B, immediate descent in oxygen, you are correct. Remember, high altitude pulmonary edema is a form of non-cardiogenic pulmonary edema that responds to oxygen and descending from that high altitude. All right, I want to thank you for joining me on this episode, and I hope it gave you the tools to identify, manage this critical condition, whether cardiogenic or non-cardiogenic in origin. This episode wraps up our pulmonary circulation series, and if you are looking for a more in-depth review of pulmonary topics, check out my respiratory playlist on my YouTube channel, Professor GPAC, and consider subscribing. If you found this episode helpful, follow the podcast and turn on notifications so you never miss an update. And remember, this is the Pro PA Podcast, where future pros in medicine are made. I'll see you soon.